Thank you for coming for this important and timely topic. We are rapidly approaching 2015 deadline for the Millennium Development Goal. A number of countries are still behind their target. And when I travel to countries, I can see that ministries of health, NGOs, and donors are getting anxious and nervous about meeting the MDG. And there are a number of questions being asked around performance of health workers. I see a lot of services being now moved closer to where people live, which brings issues around task shifting. Ministries concerned about providers being taken away from their site for training in hotel rooms. I see governments complaining about low impact of training, that training is costly, that they're looking at quantities of providers that they have, the quality of training and how to design training. All these issues, the other day I saw a bumper sticker that says, training is not the solution. And I think that what the bumper sticker should say is, bad training is not the solution, or poor training is not the solution. And I think the panel here today is here to explain to us what good training is, what you need to do to improve provider performance. And if we do that, we will help countries achieve the Millennium Development Goal. So let me start these sessions with Alex. He's going to give us a preliminary finding from a landmark systematic review that is funded by the Bill and Melinda Gates Foundation, CDC, and World Bank. And they're looking at strategies used to improve healthcare providers' performance, and looking at more than 500 publications. And then that will give you the broad overview framework. And then we'll go and look at in-service training, efficiencies, efficacy, sustainability of in-service training. And then we'll zero into training design with Julia. So let's start with you, Alex. Alex is a medical epidemiologist with CDC, the CDC malaria branch. He is an MD from Cornell University and MPH from Emory University. He's been working at CDC since 1994, 2 years in the Chronic Disease Center and 5 years in an international child survival unit, and 10 years in the malaria branch. His key area of interest are health worker performance in developing countries for all disease, not just malaria, strategies to strengthen health system monitoring and evaluation methods, and systematic reviews. Alex is also the author and co-author of more than 40 scientific publications. So, Alex.
Great. Thank you very much. It's really a pleasure to be here, and I'd like to thank the organizers for this opportunity to present some preliminary results on this review. This slide shows my co-investigators, so Samantha Rowe at CDC, David Peters at Johns Hopkins University, Kathy Holloway at WHO, John Chalker at Management Sciences for Health, and Dennis Ross-Degnan at Harvard Medical School. And at the bottom I've said not all have reviewed this presentation, so don't blame them. I'd also like to acknowledge the many people who have worked on this project over the years. Also, a special thanks to investigators who have responded to our queries, some of whom are in this audience, and also thanks for the funding from the Bill and Melinda Gates Foundation, CDC, and the World Bank. Okay, presentation objectives and the caveat. First, I'll provide an overview of the project, share some preliminary results with a focus on the effectiveness of training, and third, discuss some early conclusions and next steps. And then the caveat at the bottom of this slide is that the database is not yet final, and so the results are really to illustrate the methods and to stimulate some discussions, and certainly don't quote them as final. And I've got a little caution sign here as a reminder. Okay, some background. So healthcare providers, or HCPs, play key roles in improving health and coverage of health interventions, such as medicines, vaccines, and insecticide-treated nets for malaria. And in low and middle income countries, however, HCP performance is often inadequate. And by performance, for example, I mean adherence to clinical guidelines. And then most existing reviews of strategies to improve performance have important methodological limitations. Most of the reviews on this topic focus on one strategy at a time. For example, only looking at training or only looking at audit and feedback. However, key questions for program managers and donors are usually not about one strategy. I do a fair amount of work for malaria, supporting the President's Malaria Initiative, and if I'm around the table with a program manager or others, it's not often that someone will pipe up and say, what's the effectiveness of job aids? Rather, the questions that they pose are broader, such as on this slide, what are the best ways to improve health worker performance, and how much will it cost? So to answer these broader questions, multiple strategies must be examined together in the same review. So that brings us to the Healthcare Provider Performance Review. And here are the objectives. So the idea is to conduct a systematic review of all strategies to improve HCP performance and related health outcomes and produce the following. First, a library and database of studies on improving HCP performance for policymakers, researchers, and others. Second, produce a report and summary articles on the effectiveness and costs of the strategies. And third, and this is the real goal, is to develop evidence-based guidance on how best to improve HCP performance in low and middle income countries. And finally, develop a research agenda to help fill any important knowledge gaps. Moving on to the methods of the review, here are the inclusion and exclusion criteria. For the source of the studies, we included both published and unpublished reports. For the timing, the literature searches were completed in 2008, but new reports were allowed for studies that had already been identified. So it wasn't uncommon to find an unpublished report, and then by the time we got around to abstracting it, the authors said, oh, well, actually, it's been published. So there are some publications after 2008. Regarding the type of health condition, there were no exclusions, so performance related to any health condition is acceptable. And regarding the definition of HCPs, we had a very broad definition, so facility or community-based health workers, pharmacists, shopkeepers who sell medicines, and private sector health workers. So it's really just about anything, with the exclusion being maybe someone at the household who is taking care of someone else in the household. But otherwise, it's quite broad. Regarding the types of outcomes, we were interested in direct measures of HCP behavior. So, for example, tasks related to diagnosis, treatment, or counseling. We're interested in patient outcomes, such as mortality, and others, such as economic outcomes, HCP knowledge, and so forth. And there were no exclusions due to the language of the study. Regarding the eligible study designs, the three designs that we considered are shown on this slide. So a pre versus post-intervention study with a comparison group with or without randomization, post-only studies with a randomized comparison group, and then interrupted time series with at least 3 data points before and after the intervention. And this goes along with the definitions that the Cochrane collaboration uses for their systematic reviews. Regarding the search strategy, we searched 15 electronic databases, some of which are shown at the top of this slide. Second, we performed a hand search of bibliographies from 510 previous reviews and other articles. Third, we searched document inventories and websites of 29 organizations involved with HCP performance, a few of which are shown on this slide. And fourth, asked colleagues for references in unpublished studies. For data abstraction, we did a double independent abstraction with a rather detailed 20-page form, and the data were entered into an Access database. Queries were often sent to authors for clarifications, additional details on methods, contextual factors, and so forth. And so as a result, to some degree, the HCPP database contains more than what's in the original reports. Not to say that the database replaces the reports, but we've gotten extra information that you really couldn't find unless you contacted the authors. And that's one thing that's nice about this project. Okay, regarding the effect size, a typical effect size would be calculated by the formula in yellow at the top of this slide. So you take the post-intervention value minus the pre-intervention value in the intervention group, and from that you subtract the post minus pre-intervention values in the control or comparison group. So a simple example is shown. You can see a graph that is some indicator of performance, for example, the proportion of patients treated correctly. In green is the intervention group, and the indicator improves from 25% to 50%, so that's a 25 percentage point improvement. And then in blue, in the control group, perhaps the indicator goes from 20 to 30%, and so that's a 10 percentage point improvement. And the difference between those two is a 15 percentage point effect size. And this is known as in some circles as an adjusted risk difference. There are a lot of different terms, but that's one of them for those of you that follow that. And so the effect size is in terms of a percentage point change. And we calculated effect sizes so that a positive value meant a success or improvement. And that's because there's some indicators of performance that are intended to decrease. So we flipped those around so that we could compare all of them. Only primary outcomes were analyzed, as per what the authors described as the primary outcome or other evidence in the paper. And if a study had more than one primary outcome, we took two different approaches. First is to take the median effect size from the primary outcome, so the median being the middle effect size, thinking that that's the best overall effect size for a particular study. And also, and I'll show an example of both of these, the second is to analyze the effect sizes differently, and that's because the median effect size can mask a tremendous amount of variation. Okay, there were a lot of outcome categories, including processes of care, health outcomes, utilization, economic outcomes, and of those, most of them could come either as be a dichotomous outcome that would be expressed as a percentage, or as a continuous variable. For example, mortality might be an example for that. And it's very difficult to decide how to lump or how to split these all out. And so, as shown in the second half of this slide, we're now considering at least 4 separate analyses, and the idea is to have more of an apples-to-apples comparison between the different strategies. So the 4 approaches are looking at dichotomous process outcomes, and so an example of that might be the proportion of patients correctly treated, but also continuous process outcomes is a second category, a third being dichotomous health outcomes, and the fourth continuous health outcomes. But this is a particularly difficult part about this data set, is the heterogeneity in outcome categories. Okay, a word on the conceptual framework, the guided data collection, and is guiding the analysis of strategy effectiveness. I could spend the whole hour on this, but just to give you a flavor, since we can only, the time is quite limited. So the central question of this framework is what might influence the observed effect sizes from studies in the review. So at the top, the first bullet is the strategy to improve performance. Well, clearly that's the primary attribute that we're interested in. That's why we're doing the whole systematic review. However, other factors are also important. They could be confounders or they could be effect modifiers of the strategy-effect size relationship. Also, some of these factors reflect the generalizability of the studies, that is, to what other settings would the study results apply. And so examples of these other factors include the study design, data collection method, the follow-up period, the type of health worker, and the setting. For example, public versus private health facilities, inpatient versus outpatient versus drug shop. And so incorporating these other factors is likely going to be quite important, but quite challenging for a variety of reasons. But I wanted to say a word on that conceptual framework, and we'll actually come back to this a little bit further on. Okay, so some preliminary results, and you can see my little caution sign in the corner. Okay, the literature search. More than 105,000 citations were screened, and 2,744 reports were found on improving health worker performance in developing countries, and that's all study designs combined. Of those, about 1/3, or 849 reports, were from studies with eligible designs that I presented earlier. And about 2/3, the remaining 1,600, were reports with other study designs that were more susceptible to bias, and so we didn't include them. Plus, we couldn't really abstract 2,400 reports. So. And then the 849 reports that we're including correspond to 509 studies. So the 509 studies included a total of 729 intervention arms. That is to say, 729 strategies to improve performance were tested in this group of studies. And to date, we have comparisons available. We have 685 comparisons available. And so to explain this a little bit, about 2/3 of those, or 446, are a comparison where a strategy, for example, let's say training, was compared to a no strategy or a no intervention control group. but then there were another 239 comparisons where one active strategy was compared to another in the same study. Most strategies had multiple components. So for example, if a strategy in a study was training plus supervision, that was considered to be 2 components. And there was a median of 4 components per strategy, ranging from 1 to 20. So it was very common to have multiple components in a single strategy. And this gives you a flavor of what those strategy components are. I've collapsed them down to 12 relatively simple categories. And keep in mind that the percentages add up to much more than 100% because multiple strategies were allowed per study. So at the top, by far, the most common was training. In about 3/4 of the studies included a component of training. About half had some kind of community activity, such as community education. A little less than half had job aids. A little less than half included some other kind of quality management approach, such as total quality management. About 1/3 included supervision. 1/3 had some kind of institutional change, for example, creating a new cadre of community health workers. And about 1/4 had a new standard treatment guideline as part of the strategy. 1/4 had some kind of new system, such as a drug management system. 1/4 included some sort of financial-related components, so incentives or contracting. About 1/4 had the provision of commodities as part of the strategy. Less common were strategies affecting the source of revenue, such as pooling or insurance schemes, a few on regulatory approaches, and then there are still a few more that we have to code. So where were the studies done? They were done in 83 countries, and some of them were done in multiple countries. And 55% were from low-income countries, with the remaining 45% coming from middle-income countries. Geographically, a little over 1/3 were from Africa, about 1/4 in Southeast Asia, and you can see the rest of the slices of the pie for other parts of the world. Other study attributes, easily could spend an hour on this, so just to give you a really quick picture of the kinds of studies that we're talking about. So the places where where services were delivered, outpatient health facilities, hospitals, pharmacies and shops, households, and many others. And you can see the percentages, but I want to go through this quite quickly so that we can get to the good stuff. So the study setting, about 1/3 in public health facilities, a little less than 1/3 in community settings, also the private sector, but many others really. For the HCP type, 40% of the studies included physicians, a little over 1/3 nurses, about 1/3 community health workers, but there were also midwives, nursing aides, and many others. Regarding the health topic, about 1/5 of the studies were on safe motherhood and antenatal care, about 1/5 on rational drug use, about 1/5 on family planning, but also many on infectious diseases, non-communicable diseases, and so forth. And then regarding outcome type, 14% on treatment, patient compliance, about 11%, 10% had some measure of morbidity. There was also mortality, other case management attributes, and so forth. Sorry, that was very quick, but just to give a quick flyby. Okay. So now preliminary results on the effectiveness of the strategies. And I'll present 3 methods, and for each, I'll present the method, describe the method, and then give a sense of the question that the method was intended to answer. So the first one, the description is that for studies that compared a strategy to a no-intervention control, the idea was to create a histogram of the median effect sizes, and this is combining all strategies and all outcome types. So the question that this method attempts to answer is as follows. Overall, regardless of strategy and across all studies, how much improvement typically occurred compared to doing nothing? So this is a histogram of 446 median effect sizes from 379 studies, and it's all strategies combined with a no-intervention control group. So it's a histogram, so the x-axis is the magnitude of the effect size. Again, it's a percentage point change, and the y-axis is the number of median effect sizes. The median of this distribution, so the center of this distribution, which is shown in blue on the right side of the slide, is 7 percentage points, with an interquartile range of 1 to 23 percentage points. So what does this mean? It means, as shown in black here, that 1/4 of the effect sizes was essentially no effect whatsoever, less than 1 percentage point. That's the first quartile. The second quartile is still quite small, the effect size is quite small, 1 to 7 percentage points. And together, what this means is half of all effect sizes were small, 7 percentage points or less. The next quartile ranged from small to moderately large effect sizes, 7 to 23 percentage points, and then the last quartile had a larger range of effect sizes. So part of our work is to try to understand what gets you into the right side of this distribution. But now we'll get into that question a little bit. Okay, new method. Method number 2. The description of the method is to group the strategies according to their components. So if there was a strategy and the components of that strategy were training plus job aids, nothing else, then that would be one strategy group. And then for studies comparing a strategy, again, to a no intervention control group, show the range of median effect sizes for each of these separate strategy groups. And for this analysis, I'll only examine dichotomous process outcomes only. So for example, the proportion of patients treated correctly. And that's, I mean, I could show, there are a lot of other ways to look at the outcomes, but for time purposes, I thought I would just show this one first. And this analysis includes 161 studies. So the two questions that this method attempts to answer, as shown on the bottom of this slide, is first, how much does each strategy group typically improve processes of care? And second, which strategy groups are most and least effective? Okay, so when you go through the process of creating these strategy groups, you get a lot of them, 97 unique strategy groups. And so 69 of these groups have only one study each. So very little evidence. 19 strategy groups have 2 or 3 studies, so a little bit better. And 9 strategy groups have 4 to 19 studies each. So there are many groups, most of which are evaluated by few studies. In fact, most of them are evaluated with just 1 study each. So for the purposes of this presentation, as shown in the green box, I'm going to present the effectiveness of just the 9 strategy groups with the most amount of evidence. I'm not saying that these are the most or least effective. It's just these are the ones that probably have the most stable estimates of effectiveness. Okay, so the setup for this is that across the top, the x-axis at the top of the group, top of the slide, excuse me, is going to be the effect size. Again, is a percentage point change. And for each group, each strategy group, there's going to be a line and a little diamond in the middle. So the diamond is the center, is the median of the different effect sizes. So it's the centermost value, just to give you a measure of central tendency. And then I put that number on the right-hand side so you can actually see what the number is. And then the blue line indicates the range of the median effect sizes, so the minimum and maximum, to give you a sense of the variability. Okay, and then I've ordered the strategies by effect size, which has ended up being kind of a David Letterman approach, which was not my intent, but anyway, here we go. So at the bottom, job aids only, a median effect size of 1 percentage point. Training plus supervision plus job aids plus other quality management, 5 percentage points. Training plus job aids, 7 percentage points. Supervision only, 10. Training plus supervision plus job aids, 11. Training only, 12. Training plus job aids plus other quality management, 12. Training plus job aids plus community activities, 18. And at the top, training plus supervision, 27 percentage points. Now, for those of you who, some of you may be bothered by this. Some of the results, maybe for many reasons. Some of these results might strike you as being a little bit illogical. For example, does adding job aids actually worsen performance? So if you look at the top, not the reaction I was expecting. Anyway, so at the top you can see training and supervision, that median effect size is 27 percentage points. But if you go down 3 or 4 rows, there's training plus supervision with and then you've added job aids. Now, if job aids are completely not helpful, then you would expect maybe that these two values would be very similar. That if you just add job aids, even if they're not effective, the overall effect size would still be around 27 percentage points. But in fact, it's quite a bit lower. And then if you go down even further and add other quality managements plus the job aids plus training and supervision, it's way, way lower than 27 percentage points. Okay, so does adding job aids worsen performance? No, we don't think that that's a plausible explanation. Rather, The two things that struck us was that first, these are very wide ranges, and so you have to consider the variability within each of these. And that's why you can't really do a simple comparison of this type. Maybe I should have said that at the beginning. But also, it's also likely that there are contextual and methodological differences that influence the observed effect size from these studies. And that gets back to the conceptual framework that I presented earlier. I think it'll be really important to look at those factors so that you can have some sort of adjustment so that you can really have a fair comparison. Otherwise, these differences might be really quite biased, and that could really lead to the wrong answer. Okay, new method. A preliminary results on the effectiveness of strategies with a focus on training. And this gets to a slightly more sophisticated method that helps address some of the problems that have come up earlier. So the description is to only analyze strategies that include training, not surprisingly. And then for studies that were comparing a strategy to a no-intervention control group, create a statistical model with attributes of training strategy, the training strategy in the model. For example, training duration, and I'll describe those attributes in a moment. The dependent variable for the model is the individual effect sizes. That allows for greater variability that can be masked by the median effect size. And then I'll be examining, just as with the last analysis, I'll be examining dichotomous process outcomes only. For example, the proportion of patients correctly treated. So the question that this method attempts to answer is as follows. What are the attributes of the most successful training strategies? Or in other words, how do you improve the effectiveness of training? Okay, so here's, this is the setup for the linear regression model of the strategy effect size that includes training attributes, baseline performance level, and other components in the strategy. And for those of you interested in the guts of the statistics, this is adjusted for the clustering of effect sizes within studies. And that's because effect sizes from within a particular study are more likely to be similar. And those adjustments were made using generalized estimating equations. And I can get more into details in the Q&A if you're interested. But let's look at the model a little bit more carefully. So the three training attributes included in this model, first are training duration between 1 and 14 days. And that's because almost all of the values of training duration were in this period. Second is the training methodology, the actual educational methods. And it's a slightly odd variable, but it's all four quote-unquote key methods versus not all four. And the four key methods are shown at the bottom of this slide. So clinical practice and interactive lectures or sessions and non-interactive lectures or sessions and role play. So the idea is that this variable gets a value of 1 if it includes all four, and 0 if it includes anything less than that. And all of them has to include at least 1. The third training attribute was multiple versus single topics. And this is because there's been a concern that if you load a training with very complicated content, it might be less effective. So that's a variable as well. In addition, baseline performance level is included in the model because there have been other studies that have found that interventions can be more effective when baseline level of performance is lower. And then the last is a group of 10 indicator variables that code for all the other interventions, all the other components in the strategy. Because very few studies look at training by itself. Most of them will include, supervision or a job aid or both and onward. Okay, so you probably want to know what the actual results are, so sorry about that. So here are the model results, and we'll go through them one at a time, try to make sense of this. Okay, so starting in the red box, training duration. What this says is that on average, effect size increased by 1 percentage point per added day of training, adjusted for everything else in the model. The result is statistically significant, which means the result is unlikely due to chance. Okay, so what does this really mean? If this model is correct, and remember these are preliminary results, if this model is correct, and if this model can be generalized to the setting where you want to work, then kind of the key message is in green, lengthening training by just a few days has predicted to have this model would predict to have a very small effect. So if you're going to make a training more effective by increasing the duration, you have to increase it by, a good 10 to 14 days. Next, training method in the next red box. So on average, the effect size was 11 percentage points greater when all 4 of the key training methods were used as compared to not using all 4. Adjusted for everything else in the model, and the result is statistically significant. Note, something that's not on this slide is that the individual methods, none of the individual methods were effective in isolation as an independent effect. There was only a significant effect when all 4 were together. So again, if this model is valid, and if it can be generalized, then sort of the take-home message, if you will, is that all 4 methods should be used, regardless, and this is what's important, regardless of other attributes of training. So even if the training is short, what this model says is all 4 components, or all 4 methods need to be used. Okay, multiple versus single topic. On average, the effect size was 2 percentage points smaller for trainings on multiple topics compared to a single topic, adjusted for everything else in the model. However, the result was not significant, so that -2 is indistinguishable from 0. So again, if this model is correct and can be generalized, it's basically saying it's okay to train on multiple topics. It's unlikely that just by having more complex material, it would have a negative effect. Baseline performance, again in the red box. On average, the effect size decreased by 0.2 percentage points for every 1 percentage point increase in baseline performance, adjusted for everything else in the model, and that result was significant. So what this is saying, if the model is correct, is that training has somewhat larger effects when the baseline performance level is lower. Okay. Other analytic approaches, there's not time for the results, so stay tuned, and other uses of the database. Okay, so this is just a tiny little bit of our to-do list. First, in the analysis of studies that are head-to-head comparisons, right? Strategy A versus strategy B, as the contextual factors are more likely to be homogeneous within head-to-head trials. 2, there are many other contextual factors that can be examined: HCP type, setting, country, patient type, on and on. We have lots and lots of detail in this database. 3, explore cross-cutting questions. For example, are the strategies more effective if the HCPs help develop the strategies themselves? That's actually a data element in the data set, and it's a hypothesis that we wanted to test a priori at the beginning of this project, and there are a few other neat ones like that. 4, economic analyses, cost and cost effectiveness, and lots of others. Okay, other uses of the HCPP database and the associated library. First, important to mention that the database will be made freely available sometime next year when we finish cleaning it up and getting the documentation together. And then also, researchers, policymakers, and others can do the following kinds of things with the database. First, they could find studies of a particular health topic or setting. So for example, studies just on maternal health care, or just hospital studies, or just community health worker studies, or only studies in the private sector, and so forth. It's very easy to pull out those studies, and then all the results are already kind of pre-digested and vetted because of the systematic review. Plus, there are often details from the authors, as I mentioned, that can help in some ways make the database a little bit more helpful even than the studies themselves. Second, someone might want to find studies on a particular strategy. I mean, someone's maybe very interested in incentives or insurance schemes or something else. And third, people can perform their own reviews, including rapid reviews. And I mention this because I work in the malaria branch at CDC, and from time to time there will be some question that comes up, and someone wants to, answer some question, and ideally you should use a systematic review, but people shrug their shoulders and say, well, I don't have time to do a systematic review on that. And so the idea is to do sort of a quickie review, and those are often very unsatisfying. Well, the idea is that this database could allow you, at least for those studies in the database for the elements that we have, would allow a rapid review that benefits to a certain degree from the systematic methodology that was used. Okay, oh gosh, limitations, and I could spend an hour on this one, too, actually. So first, there's a considerable heterogeneity among the studies, the settings, the outcomes, methodologies, the interventions themselves. There are many challenges with statistical modeling, and the problem with statistical modeling is that you get results that look just like science, but if the models are junky, then the results are worse than junky. They actually could be pointing you in the wrong direction. And then finally, precision is very hard to assess. And one of the major reasons for this is that a lot of these studies use cluster sampling, regardless of whether or not the authors recognize that. But the analyses rarely incorporated that clustering in the analysis. And so it becomes very difficult to assess precision. And anyway, that's another main challenge. A few very early conclusions. First, there's a surprisingly large evidence base on the effectiveness of strategies, with many strategies tested in many settings. Sometimes you'll pick up a paper on this topic and it'll say, few studies have been done on, I don't think anyone's allowed to say that anymore. Second, there's considerable heterogeneity that makes the analysis and interpretation quite challenging. Third, the effect sizes vary substantially, and many of them are small. But some of them are large, and so it'll be interesting to try to understand where those large effect sizes are. Fourth, analytic approaches can identify factors associated with higher effectiveness. So, for example, I did the example for training, so the four key training methods or longer duration. And what's interesting, I think, is that, and perhaps what's a little bit new, is that, to a certain extent, these results aren't rocket science. Longer duration of studies are going to be, of training is going to be more effective. Well, I mean, I think anyone could have guessed that. But what's nice about this analysis is that it begins to quantify what that effect is. And I think that's something that would be, hopefully will be a contribution of this project. A few more early conclusions. The evidence base, by my standpoint, seems fragmented. Researchers don't always seem to be building on each other's work, although now at least I can understand why it's sometimes hard to find other people's work. 6, standardizing methods and outcomes would greatly facilitate efforts to summarize the evidence base and develop effective and practical recommendations. And this is something we need to seriously think about, especially those people who are funding this kind of research. Because if we end up with, if 20 years from now or 10 years from now, we end up with, just more of the same, it's like a gigantic yard sale. Lots and lots of stuff sitting out there, but very little of it's connected, and it makes it hard to make sense of. And then finally, I think this review is unique in the field of health systems research in developing countries. It includes all strategies. It has an unexpectedly large size. It has a rich database of contextual factors and many other details, and many extra details from authors. A few next steps. So over the next month or so, I'll be presenting, getting feedback, and refining the analysis. Hopefully, February or March, draft a report and send it out for external review. And we're hoping for a dissemination meeting in Atlanta, April, maybe a little later than that, but don't tell my thunder. And then, for the products, there'll be the library of studies, the final database, which I said will be publicly accessible, a detailed report and some summary articles, and then other dissemination activities. Thanks so much for your attention.
Thank you, Alex. This is just fascinating. We'll be here when you are ready with the data, when you are done. We have time for a few questions from the audience. And while you are thinking of, okay. Please introduce yourself.
Mary Hamill from CDC.
Okay.
It should be. It was earlier.
Can you try it and see?
You can ask it and he'll repeat it. Go ahead.
Thank you, Alex. That was excellent. It just packed with information. I have a lot of questions, but I'll limit it. First, I have 3 things I'm asking. I want to know if you have any way that you're going to quantify the supervision in your analysis. Secondly, you showed these strategy groups, and you showed us those that had repeated studies. But I'm wondering if there were any with such large effect size that you might just comment on what those are, if you can remember them. And lastly, and you're allowed to change this response in the next few months, but could you have so much knowledge right now about this. If you were to go out tomorrow and design a training for IMCI or malaria and pregnancy, can you tell us what your key elements would be that you would include, your key strategy for that training that you would include, and maybe it goes beyond what you've shown us, but draws on some of the other information you've gleaned through your review.
Great, thanks a lot, Mary. Regarding the quantification of supervision, for most of the strategies, for most of the strategy components, we pretty much just coded whether or not the component was present or not. But for two components, training and supervision, we actually collected additional data elements. Obviously, the training results, I've showed you some preliminary results on training. For supervision, then, we looked at, I think we collected 3 additional attributes. One was whether or not the supervision included feedback. Second was, did the supervision include a checklist? And third, what was the frequency of supervision? So if all goes well, we'll be able to conduct a similar kind of analysis on attributes of supervision. Regarding the strategy groups, which have the largest effect sizes, I intentionally tried not to memorize any of these results because it's really too early to say. I could, of course, I could pull out what's on the far right-hand side of that histogram, and in fact, that's one of our approaches. Some people call it a positive deviance analysis, to try to look at the most effective strategies and try to understand what common elements do they have. So that's something that we are planning on doing, but I don't have anything right now. And as far as your last question, you put me in an awkward spot because I keep putting oh my God, where's my little caution sign? So pretend there's like a big caution sign that is covering my mouth so I can't really say anything. I mean, I've obviously shown the results from the training analysis, and they are what they are. They're preliminary results. They show some interesting findings, I think. I'm not going to make any recommendations right now, and I think it'll be really important to understand what's happening with the other components of these strategies. And to be honest, you have to ask the question, even though we may be here to talk about training, maybe that's the theme of this event today, but really the hidden question may be, is training really all when is it that training is going to be the right thing to put in, and what should the mix be if it does include training? Right? Training, what can it do? I mean, it can improve knowledge, it can be a way to get health workers to emulate the trainers if there's a certain degree of respect. I mean, there are a number of mechanisms through which training could theoretically work. But those aren't always what the problems are. And so really to understand what the problem is, to know, are you using the right tool for the right problem, I think are all part of the difficult questions that need to be answered. So that's a very clever way of not answering your question. I'm sorry. But stay tuned, because we will come up with what we'll do is we'll try to say as best we can what the data are telling us.
Kate Telenko from Capacity Plus. Thank you so much for the presentation. It's just incredible. And I have a comment and a question. One is, it's so interesting to see that supervision came out as one of the strongest factors. And to me, it just shows that when you get the basics right, the quality follows, because supervision should be part of any health worker's job. And then the second is a question that you kind of just touched upon in your last comment, but in reviewing these, was there a sense that any type of diagnostic was done on these facilities? Or in other words, why was that intervention done in that facility? I mean, was it because the researcher was interested in total quality management and these were the facilities that she had access to? Or, was it known that there was a problem with drugs at this community and so they provided commodities? Or, so was there a diagnostic done, or was it just, matching up what people were interested in the facilities that were available? Thanks.
Yeah, thank you for the question. And she was not a plant. There's actually a data element in the data set that looks specifically at whether the intervention, whether the strategy was designed to address a particular obstacle or problem, a quality problem in the study site. So that's actually a hypothesis that we will directly look at. That was one of our a priori hypotheses. So,
yes, go ahead.
Hello, Kathleen Hill with URC, the Assist Project. Thank you very much. That was really interesting. I had a specific question and then a slightly more general question. One was you were showing us data related to dichotomous continuous variables, and I'm wondering if you've done any preliminary analysis of the non-dichotomous continuous, because the dichotomous continuous, I'm assuming, are mainly, it's either all or nothing. Either the care was compliant with the guidelines or it wasn't, and we know that very often performance is more incremental. So I'm wondering if you have any data related to that variable, and you may not. And then the other question is coming back to, I think, what's come up around, what package of strategies is most effective. And I was interested by something you'd said about when providers themselves become involved in the training. And I'm wondering whether, particularly in any of the middle-income research studies, any data was collected around use of continuous professional development, CPD as a training strategy. We're seeing a lot of that now emerging in middle income, and I think this may be an intriguing direction as well, so that it's not a one-off training or supervision, but it's really integrated into an overall framework of continuous professional development.
Great, thank you. I'll answer these in reverse order because the second one was easy and the first one was hard. One thing that we looked at when we categorized the training is whether it was a training of discrete duration or whether it was ongoing training. I don't know whether the ongoing trainings were necessarily part of the development that you're describing, which sounds fairly sophisticated and, sounds like a great idea, actually. It might have just been that that's just what they came up with. Like, I don't know, logistically, maybe they wanted to have a half-day training once a month, and that's just what they decided to do. So we have that variable, but I can't, unless it's something that may be coded in the description of the strategy itself, what the purpose of it was. So it might be in there. We unfortunately have a lot of text boxes, so yeah, right. So it's hard to analyze, but that's something that we can look into, and we'll be going through all the text boxes for the strategy components, definitely. Regarding the continuous versus dichotomous, I think maybe I might have misspoken. So one way that we divided up the outcomes was whether it was a dichotomous outcome, that is an outcome that could be expressed as a percentage. Let me explain. Okay, so it's a little bit more complicated. So the dichotomous, that category, that is an indicator that you could describe with a percentage, came in two sub-flavors. One was a truly dichotomous outcome, like literally did it have a value of yes or no, and when you take an average of that, it's a percentage. But there were also some outcomes where it was a percentage for each individual patient, let's say. So for example, the proportion of tasks that were done correctly. And so if you take the mean, if every individual is a percentage, gets a value that's a percentage, and you take a mean of that, it's still a percentage. So it's not strictly speaking a dichotomous outcome, and in fact, that's probably something that we need to clarify. It's not a very good label. And then the continuous variables are things like counts. So, deaths or number of IUDs placed or dollars spent or something like that. Anyway, I don't have results specifically on that, but that's something that we'll clearly get into.
Andrew Mitchell, Office of the U.S. Global AIDS Coordinator. I think as...
we are not hearing you.
Sorry. Andrew Mitchell, Office of the U.S. Global AIDS Coordinator. I think this analysis has a lot of potential to really inform, as people, I think, are picking up very specific ways and elements of trainings to emphasize. One result I was intrigued by in the model, and now you'll have to let me know if I'm interpreting the model correctly, was the intercept had a effect size of 22, I believe, positive 22. And if I'm understanding this model correctly, that means independent of all the other variables in the model, just the fact of having any kind of intervention led to a 22% increase in outcomes. Now, tell me first if that's a correct interpretation of this particular.
Yeah, it's partly correct. So the intercept would be the predicted effect size if all the other variables had a value of 0. So that would mean a training duration of 0, which doesn't make sense. So you would have to put in at least a training duration of a day. But that gets you to 23 percentage points. The training methodology would have to be not all 4. the topic complexity would have to be single topic, and the baseline performance level would have to be 0.
Okay.
So, and there could be no other
Right,
components
right.
in the strategy. So if you look just at the intercept by itself, it doesn't make sense because it corresponds to a training duration of 0.
Okay.
Um,
Fair enough. Do you, and so with the intercept, is there any, what do you think that's capturing? Maybe this relates to the last question. What do you think that's capturing that's not in the model right now?
Yeah, no, it's a good question. I think there are probably a lot of contextual factors that may be explaining part of this. But the other is just the intercept is a little bit odd in a model like this because it reflects a situation that can exist just logically. But it's a good question. And to be honest, for other kinds of models that were not exactly the same, what we're doing is one way of helping us know whether the model looks good is actually if we can get the intercept to 0, which would correspond to the situation where you're not doing anything to improve quality. And in fact, we've got some early analyses of a different method that I haven't had time to present, where we've gotten intercepts down to like just 2 or 3 percentage points that's indistinguishable from 0. But yeah, the intercept is a little bit of an oddball here. And that's the problem of preliminary results. Beware of epidemiologists bearing preliminary results. So. And I do appreciate your patience, given that you probably want to hear final results, but have to wait a little bit.
Any other question? Alex, tell me, what has been the biggest surprise for you so far?
The biggest surprise is the sheer amount of studies. When we started this, we had not a very ambitious plan. There had been a systematic review that was very nice, ended up not getting published, that had been produced by INRUD, the International Network for the Rational Use of Drugs. And they had 36 high-quality studies, and then that was in 1996, and then they updated it and got a few more in 2001. We thought, okay, and when we started discussing this in 2006, we thought, okay, well, we'll find a few more studies, maybe a total of maybe 80, maybe 100 max. And then other people who joined the study team wanted to expand it a little bit to include more of the economic strategies. And I'm glad we did that because those are important, and it would be pretty awful if we had left those out. But it expanded the search somewhat. But then when we were done, when we found 500, and these aren't just 500 studies, these are 500 studies filtered with the best quality of the designs. Mm. It includes 210 randomized trials. I never would have guessed that at all. Mm. And in fact, we almost had to shut the review down because we didn't have funding, and we didn't have anything close to that. And actually it was Gates that swooped in and basically saved it by giving us the funding that we needed. And to thank them, we've missed every single milestone because it's been so complicated. So, yeah, no, but anyway, I think that was the biggest surprise.
Okay. I believe we have one last question there.
Yeah, just some last food for thought, perhaps. Rachel Dessum, IntraHealth. I was curious to know, it seems that some of your systematic review may also allow to know for who is delivering the training or the intervention, or whether public, private sector, et cetera. And then some other things that came across my mind that may not be possible given the nature of reports, but knowing governance, programmatic, implementational elements. So, was this intervention shot from the start because of contextual issues, conflict, governance issues, et cetera? I'm sure a lot of us here would also be interested to know about the costs involved and what kinds of cost share there may be, whether there was involvement from those who are benefiting versus others, and I guess some other issues around sustainability. Nothing that I expect you to answer, but things that perhaps those that would use the database in the long term would love to also be able to examine.
Yeah, good questions. Let me take a quick stab at each of these. So regarding who is delivering care, yes, we do describe not only the type of provider, but what the setting was, public versus private. And in the private sector, we've broken it down into for-profit, not-for-profit, public-private cooperatives, and I guess not specified. So for people interested in the private sector, there's a little bit of detail there to examine. Regarding kind of other more general high-level contextual factors, boy, if there's an element here, we have a text box for it. We have a text box on contextual elements of the type that you're describing. How we code those and how we analyze it seemed like such a good idea at the time. So not only I don't know exactly how those data would be analyzed, but the details there. And the other problem is that we didn't always go back to authors to ask for when a data element, when a particular dimension of a study or a strategy or whatever wasn't present, we couldn't always ask, are you sure it wasn't there? We only asked about things that were really clear omissions or if something didn't make sense. So maybe there was terrible conflict and the people who did the study knew about that, but it just didn't get into the study report, and so we didn't know to ask them about it. Now, if there was some little hint of something, we might have then asked about it, but the problem is the reports, the quality of the reporting in the reports was extremely variable, and there were some instances where the reports you could literally just fill in the entire database, no problem from what was in the report, and other times we had asked, 10, 15 questions to the authors. So that one, it's there. I don't know the quality of it. Let's see, what's next? Oh, cost. So there's a whole section just on cost, and it's all over the map as far as what the measures are. And so I haven't even. I need to rest before going into that, but it's definitely there, and we know that we want to. We know we want to do it. We sort of put it in there because we knew that we had to do it, and we also had a sense. Because all of us that worked on this, we've all done studies and we've read zillions of papers, and we know that in general the cost and cost effectiveness types of analyses were highly variable, often not done at all. But yeah, we will get into that. And regarding sustainability, when we abstract effect sizes or indicator values that we use to calculate the effect sizes, we have to enter in the months since intervention. And so what that means is that the whole review is one gigantic time series because we have the timing. And we worked really, really hard to get the timing as right as we could. So we got it down to roughly the month. So we think, everything may be off by a few weeks here and there, but in general, I think we did a pretty good job with that. And so to answer your sustainability question, what you can do is you can look at what point the intervention was implemented, and then you can see how far out the evaluation was relative to when the intervention was implemented. And if you have a training or something that was done in January and then there was a follow-up survey or something done the month after, that doesn't tell you much about sustainability. In contrast, there are examples, where you might have follow-up data points of maybe 4 years after a strategy was implemented. And so that would be maybe telling you quite a bit about sustainability. So I think we might be able to get at that somewhat. Great, thanks so much. I really appreciate your attention and the questions.
So we look forward to seeing the results of your study. Let us know when you are done.